Neha, you can start sharing your screen so long. Neha, can you hear me? Hello Neha, can you hear me?
Yes, I can hear you now. I'm not unmuted.
Okay, good. Yeah. You can start sharing your screen so long.
I'll do that, Prof.
Okay, you can go to your first slide.
I just want to choose what I'm only going to share because I figured this out, not to show my notes.
Okay, now take your time.
Yeah. Okay, Prof, are you just seeing my slides and not seeing my notes?
Just go to your second and third slide. That's fine.
See my notes, Prof?
No. Okay. Just see your slide. Prof. John Lazarus is going to be a bit delayed. We will just wait for another 3-4, maximum 5 minutes, and we'll start latest by 5:05 once other consultants have joined.
That's fine, Prof.
मीटिंग आहे 5 ते 6 वेळ मीटिंग आहे नंतर परत 7 ते 8 माझी रूम म्हणजे कुठली माझी रूम म्हणजे कुठली ग Neha, Dr. Majola is joining in a minute. So as soon as he joins, we will start.
Okay, Prof.
Yeah. Okay, Neha, it's almost 7 minutes past 5. Dr. Majola joined, so we need to start. Good afternoon, everyone. Today, Dr. Neha Gautam, our registrar, is going to talk about urinary tract infections and vesico-ureteric reflux. And Professor John Lazarus from University of Cape Town and Red Cross Children's Hospital and Critical Hospital will give his expert comments, but he will only be able to join in a short while. So I think due to lack of time, we will just start with Dr. Gautam's presentation. Okay, Neha, go. I see, Neha, just a second. I see Prof. John Lazarus joining. Let me just introduce him. Just give me 1 second. Hello, John. Hello, John. Hello, John. Can you hear me? I saw Prof. John Lazarus joining. Maybe just he's having connectivity issues. I will introduce to him before he starts giving his comments. I think Neha, probably it's time for you to start. It's 10 past 5. Okay, go ahead.
So good evening, everybody. So my talk on today is on vesico-ureteric reflux and urinary tract infections. The contents of this talk will be about the basics about urinary tract infections, as well as I'll be covering important topics on the embryology, anti-reflux mechanisms, and approach, as well as medical and surgical management. So to introduce a few basics about urinary tract infections, the definition is any infection of the urinary tract, and it extends from the bladder and up to the kidneys. Causes are usually related to any type of bacteria originating from the large bowel or the stool. Improper hygiene techniques contribute to developing a UTI. Also, any residual bladder volume where there's poor emptying of the bladder can result in a medium for bacteria to grow and multiply. Any structural or functional abnormalities of the urinary tract also contribute to developing a UTI. The risk factors associated with UTI development are usually abnormalities in the urinary tract. In the potty training period where there's incomplete voiding or incomplete emptying of the bladder, and infrequent urinization contributes to developing a UTI. An uncircumcised penis, any catheterization, previous UTI, as well as anatomical anomalies. So the way the spectrum of children from neonate to old child can present with the neonate in a very non-specific matter, where they may present with failure to thrive, jaundice, or even symptoms without fever. As the child becomes older towards toddlerhood or an older child above 2 years of age, they then present with specific symptoms, these being fever, frequent voiding, dysuria, suprapubic abdominal or lumbar pain that can be detected on examination. The investigations or the approach to a UTI is to look at the history. So a clear medical history needs to be taken, questioning about is it the first episode of a UTI or the second episode of UTI? Were there any possible malformations of urinary tracts in the pre and postnatal ultrasound screening? Were there any previous operations? A family history of reflux or reflux with the parents? Or are there any history or symptoms suggestive of constipation or the presence of bladder bowel dysfunction that I'll come later on and explain in the talk? The physical examination should be focused and should focus on palpating a painful kidney, a palpable bladder. Is there any flank pain? Are there any stigmata of spinal bifida or sacral agenesis? and to have a careful look at the genitalia, looking for features of phimosis, labral adhesions, vulvulitis, or epidermochitis. And then you need to collect the urine. So in the neonate or the infant that's not toilet trained, there are 3 ways of collecting urine. This is by means of a plastic bag on the clean genitalia. You can perform a bladder catheterization. The contamination rate is about 14%. And then ideally, the best form of collection of urine is a suprapubic catheter. This is the most sensitive method to obtain an uncontaminated urine sample in this age group, and it yields a diagnostic field of almost 97%. And in the toilet trained group, or the older child that's able to listen to instructions, you would want a urine midstream sample. So the way this is done is by cleaning the genitalia twice with soapy water, retract the foreskin or the labia majora and minora, and ask the child to pass urine, and you want to collect the midstream sample of the urine. And this way or technique reduces contamination to up to 8%. And then you want to analyze the urine. So the way this can be done is by dipsticks, and then microscopy, where actually the urine undergoes centrifugation, and you want to review through high power magnification of how many white blood cells are present. Flow analysis looks at the particles in the urine, and then culture looks at the exact organism that grows and its sensitivity to antibiotics. And then finally, your radiological exam or investigations, where you want to investigate any abnormalities in the bladder, the ureter, or the kidneys, which we can find in about 37% of patients. And if present, you would proceed to doing a cystourethrogram, which is a VCUG. The complications related to UTIs are abscess, formation, acute kidney injury, generalized sepsis, even reoccurrence. And then the management. So your choice of IV antibiotics or perienteral antibiotics depends on the suspicion of urosepsis, especially in the neonate, or the illness severity. Your choice of antibiotics are usually your first generation antibiotics. Usually we use ampicillin and gentamicin. You should base your choice of antibiotics on the strains in the environment you are in, and change it as per your urine culture and culture results and sensitivity. Ideally, the duration of the antibiotics should be between 7 and 10 days. It's been shown that if you use the antibiotics for longer duration, it reduces your chance of developing renal scarring. Chemoprophylaxis, so this is quite a controversial topic that I'll discuss later in this presentation. So the long-term use of antibacterial prophylaxis can be considered in those that are high risk of developing a UTI, or those that are high risk of developing renal damage, as there are some published randomized controlled trials that have come through, and they do not support the efficacy of antibacterial prophylaxis. And as I said, I'll discuss the controversies with regards to this. Last is the monitoring. So you should expect a response in the first 24 to 48 hours. If there's any delay, consider complications, obstructions, collections, or any resistant organisms. So this comes to the important question that why to investigate UTI. So at least 50% of children that have presented with a UTI have some abnormalities of the urinary tract system. And of that group, 35% present with some form of reflux. So this goes to my talk about vesica-ureteric reflux. So its highest incidence is typically in males, almost 30%, and it's very common in the age groups of less than 3 months. With regards to the embryology, there's a problem with the UVJ junction. So the uteric budding starts very early off the mesonephric duct, at least 4 to 6 weeks. The ureter gets incorporated into the urogenital system, and then it places itself in its correct anatomical position. And this position is designed in a way that prevents passive reflux and acts as a compressive valve. But if this uteric budding takes place very early, this would result in a uteric orifice to be located very high and laterally with a short intramural length. And this then causes reflux. So there are three anti-reflux mechanisms that are identified that prevent reflux. The first is the functional integrity of the ureter, which means that urine passes anterogradely and opposes any form of reflux. The other one is the anatomical composition of the UVJ. So first, it's the intramural length, which follows the ratio of 5:1. And then the way the ureter is fixed in 2 points, the extravesical and intravesical points that acts as a compressive valve. And then also the complex muscle structure within the bladder forms a deep trigone that also prevents reflux. And then lastly, looking at the functional compliance of the bladder. So the intramural ureter remains passively compressed when the bladder wall so the intramural ureter remains passively compressed by the bladder wall during bladder filling. So lastly, there are 5 grades of reflux to look at. That is a international grading system. So the first grade looks at reflux only into the non-dilated ureter. The second one is reflux in a non-dilated ureter, pelvis, and the calyces. Grade 3 is mild dilatation of the ureter, the pelvis, and slight blunting of the fornices. Grade 4 is moderate dilatation of the ureter, the renal pelvis, the calyces, and complete obliteration of the sharp angle fornices, but still able to maintain the papillary impression in most of the calyces. And the last grade, which is the severe form of reflux, is gross dilatation and tortuosity of the ureter, the renal pelvis, and the calyces, with actually no papillary impression present. So naturally, reflux does actually resolve, and it typically resolves in those who are less than 1 year of age, more in females, in siblings that present with reflux, and your low-grade reflux, as I've mentioned the different grades in grade 1 to grade 3. Also, those that present with asymptomatic presentation during the prenatal period where hydronephrosis was diagnosed, they do resolve. And also in the high grade, so meaning grade 4 and 5, have a 25% chance of resolving. So the American Urology Association had looked at 27 different reports. And from their reports, what they did find when looking at 2,000 children, so there were factors they identified that where reflux would not resolve or where reflux will resolve. And what they identified that when there's bilateral reflux, there seems to be slow resolution of reflux. But however, in the grades of grade 1 and 3, reflux does resolve faster than grades 4 and 5. So looking at the etiology and classification, reflux can be classified into primary causes. The main reason is the deficiency in the function of the UVJ anti-reflux mechanism that I've described in this talk. And then secondary, it's the overwhelming normal function of the UVJ, or there's a presence of bladder dysfunction, congenital, acquired, or behavioral in nature that is often the root cause. Then risk factors related to reflux are the age. In gender, mostly it's boys. Any associated conditions like prune belly syndrome, spinal cord problems, neurogenic bladder, ectopic kidney or renal agenesis. And then this comes to the discussion about bladder and bowel dysfunction. So any child that screens for symptoms or signs suggestive of constipation or overactivity of the bladder, it's important to screen these children in the presence of a UTI. By treating the constipation and decreasing the overactivity of the bladder, the reoccurrence or association with UTI does decrease. Therefore, exclusion of any bladder and bowel dysfunction is strongly recommended in any child with febrile and or recurrent UTI, and it should be treated if there's evidence of bladder and bowel dysfunction. So according to the American Urology Association, they have a list of bladder and bowel rehab methods that you can look up at what they mean by these rehab methods. So the presentation in this group, so antenatally, they can present with prenatal hydronephrosis found in ultrasound. Postnatally, as I've discussed the 4 different groups, so the neonate may present with urosepsis. The toddler, the infant, or the older child can present with febrile UTI, or lower tract symptoms can present with urgency, urgent continence, extreme or frequency. The investigations of choice is a VCUG, which is the gold standard. This will define the anatomical details and any deformities, and will also, you're able to grade the reflux. An ultrasound will have to look at the bladder, ureter, and the kidneys to look at any anatomical or structural abnormalities. And then your renal scans. So ideally, a DMSA scan helps to, you can screen for acute pyelonephritis. At the same time, it can function as a baseline to look for renal scarring, and then you can follow up with other DMSNs to see how your renal scarring worsens or improves. If that's not present in your facility, you can use a MAC3 scan, which is an indirect measurement of reflux. And at the same time, you can look at the split function of the kidney and how the kidney excretes. And then urodynamics. This plays an important role in secondary reflux, as I've defined, usually in your patients that have some form of spinal cord issues like spinal bifida or neurogenic bladder. The other important parameter to think about is the somatic growth of the child, i.e. that you actually take the height of the child and see if they're growing. Hypertension, screen their blood pressure, make sure that you always have a blood pressure as a baseline and always monitor their blood pressure. Look at their renal function by means of the GFR or the creatinine. And then at the same time, every time you see them, you send off urine for culture and sensitivity. So the complications related to this is that with reflux, you have an accent of microorganisms that actually reflux from the bladder and into the kidneys. And with reflux, this will increase your risk of a febrile UTI. And every time you have the presence of a UTI, this will increase your risk of renal scarring. And then this follows the concept about reflux nephropathy, that 60% of children will develop hypertension, and eventually the end of the disease process is end-stage renal disease. So with the management of reflux, unfortunately, we don't really have good scientific evidence available to actually give us clear-cut guidelines on the conservative and surgical management. We still lack a lot of prospective randomized controlled trials. So rather, we are going to follow the recommendations based on European and American urology societies. And this is what they have to recommend on the management. So the goals of management are to prevent your recurrent febrile UTIs. As I've said, every time you have a febrile UTI, that increases your chances of renal scarring and hypertension and end-stage renal disease. You want to prevent renal injury, and you want to minimize morbidity of treatment, and you want to follow up these patients. So the management options are divided into 2 groups. First thing is conservative, where you can actually surveillance these patients and wait and watch. And then as we described and discussed about the bladder and bowel rehab, you want to obviously screen for lower tract symptoms and treat these patients. And then the role of continuous or intermittent antibiotic prophylaxis that I'll discuss shortly. And then surgery. And your options are endoscopic, open surgery, or laparoscopic or robotic surgery. So now when it comes to the controversy related to continuous antibiotic prophylaxis, the reason why it was firstly considered is that the idea is that if you sterile the urine, if you reflux sterile urine, it doesn't cause any renal damage. And this was typically used in the night where there was the longest retention of urine and the highest concentration will be maintained in the bladder. But however, studies have come through and have demonstrated no benefit from this method. Here is a table of all the different studies that have been done in the past. And the latest study that we still have and still looking at is the RIVUR trial. It stands for Randomized Intervention for Children with a Vesico-Uteric Reflux Study. It's a multi-center, double-blinded study, and they basically randomized 2 groups. There were 600 children who were randomized into those that received prophylaxis and those that didn't receive prophylaxis. And what they found was the group that was given prophylaxis actually showed some benefit in developing a recurrent UTI. However, these children were followed over 2 years, and they looked for signs of renal scarring on a DMSA scan. And what they found was there was actually no benefit in the two groups. So both of them had an incidence of 8% of renal scarring. So looking at other different studies, a large meta-analysis of children was done where they almost had collected 2,300 children, and they also said there was no benefit of using continuous antibiotic prophylaxis. Another literature review had looked at children very young age, almost 2 months to 2 years of age, and still showed no benefit. Then I come to the Swedish reflux trial, quite a popular trial, where they actually took about 200 children. There were 128 girls, and there were 75 boys, and they basically divided the groups into prophylaxis, endoscopic treatment, and surveillance. And then they followed these children over a 1 to 2 year period, and they performed VCUGs, they performed a DMSA scan, they looked at the bladder function. So the results were as such. So you can see the red, which is girls, had obviously the worst outcome of developing febrile UTIs in each of the groups. So if they were surveillanced, they had the worst chance of developing febrile UTIs. But if you look in the group of prophylaxis and surveillance in the boys, the blue, you can see that it's not really significant. It didn't really show any benefit by giving prophylaxis in the boys group. And as we've said, boys are the ones that have the highest reflux, and the highest incidence of reflux is in that population. So to summarize, who actually needs continuous antibiotic prophylaxis? The recommendations are your high-grade reflux, 3 to 5, your high-risk patients, which we said the girls, those that are young, and those who present with your lower urinary tract symptoms with reflux until they're actually toilet trained, you'd want to consider giving them prophylaxis. And then looking at the circumcision status. So according to the American Urology Association in 2016, they actually said that there's a 12-fold increase of developing UTI in an uncircumcised male. So they actually recommend circumcision in boys less than 1 year, obviously who are in the higher risk groups. So I want to just stress, it's important to discuss with family the advantages and disadvantages of continuous antibiotic prophylaxis, because it has its benefits in some group of patients and it doesn't have its benefits in all group of patients. And also the issue about resistance is a problem. And then when would you consider surgical intervention? There are specific indications. So your breakthrough infections on continuous antibiotic prophylaxis or non-compliance, your high grade, so grade 4 and grade 5, with an issue of renal scarring or decreased renal function, if there's failure of renal growth, and if there's persistent reflux with puberty approaching in girls and affects their growth. The options are multiple, from endoscopic to intra and extravesical approaches. So I'll be only talking about approaches. The surgery interventions. So endoscopy, what's known as a sting operation or subuteric injection of bulking materials. And basically on this picture, the material is injected below the uteric orifice, and it acts as a way to actually close that uteric orifice and minimize reflux. And the agents that used to be used were Teflon paste or PTFE. It was relatively inexpensive, but it had problems with migration, so therefore they abandoned this. The modern day products used today are macroplastic and deflux. So deflux is commonly used. It's actually preferred as it's a biodegradable product, and it's encased with fibroblasts and collagen that stimulates an inflammatory reaction. The success rate is between 50 to 92%. But the problem is that it's costly. The endoscopic approach is more beneficial in the groups with low-grade reflux and doesn't really show any benefit in high-grade reflux. And often, as much as you repeat it 1 or 2 or 3 times, the recurrence does increase. It actually doesn't show any benefit after multiple times of using it. Then when it comes to open surgery. So the principles of open surgery are to increase your submucosal tunnel length to the ratio of 5:1. And this success rate is good of more than 98%. So the different types of approaches are intravesical, which just means inside the bladder, or extravesical. And I've listed a few operations that can be done through the suprahiatal and infrahiatal approach. So the principles behind a successful ureteral reimplantation are that you want adequate exposure of the ureter and you want to mobilize it. You want to preserve its blood supply. At the same time, you want to create a long submucosal tunnel length versus the ureter diameter ratio that exceeds 4:1. And you want to prevent angulation and twisting when you do your anastomosis. So the one I'll be describing is the Cohen cross-trigonal infravesical infrahiatal approach, which means you actually have to enter the bladder. So the first stages is that you actually intubate the ureter. You can use a small feeding tube. You can use a size 3, 4, even up to 8, depending on the size of the ureter. You want to actually mobilize the ureter from its attachments and preserve its blood supply. And then you want to create a submucosal tunnel, as seen over here, where you start from the lateral aspect and you bring it across the midline, and they cross each side crosses. And then you want to actually push the ureter through the submucosal tunnel, and you're following the ratio of more than 4:1 and complete your ureter anastomosis. You would need to leave a double J stent in these ureters. You need to drain the bladder, and then I think you keep the stents for about 10 days. And the advantage of the Cohen cross-trigonal approach is that it's simple, it's relatively safe, and it has a success rate of more than 95%. With minimal invasive surgery, laparoscopic and robotic approaches have been tried. They should actually be considered to be successful and quite easy to do, and also have less morbidity. But the problem with your minimal invasive surgery that when it comes to ureteric implantation is that the procedures are very long, there's a steep learning curve, and there are a lot of technical challenges. The procedures that have been attempted are the extravesical reimplantation. This is the Gil-Vernet procedure. So to conclude my discussion, I've decided to look at a full look at a summary of what I've described of the management and the approach of reflux. And I've divided it into two groups. So in the group of less than 1 year of age, you would have antenatally diagnosed hydronephrosis. You would opt to do an ultrasound after 48 hours in the postnatal period, document your AP diameter, and later on perform a VCUG. Then you need to grade the reflux. So in the low grades, these are the group that you can follow at 3, 6, and 9 months. With the higher grades, obviously require regular follow-up, and this is the group you would choose to give continuous antibiotic prophylaxis. And then those that present with urosepsis, like the neonate, you would admit, treat with IV antibiotics, perform a MCUNS, and actually send it off for culture, and also estimate the GFR. And at the same sitting, you want to do an ultrasound to look for any abnormalities as well as hydronephrosis. Later on, you perform a VCUG, you grade your reflux, and then consider doing either if a DMS scan is available in your facility or a MAC3 scan to check the function as well as the excretion of the kidneys. If you have a patient that has repeated UTIs, consider secondary reflux and then consider urodynamics in this group. And then in the child over 1 to 5 years of age. So they typically present with febrile UTIs. You want to do a clear history and examination. Sorry, I don't know what happened.
Yes, yes.
Sorry.
Okay. Yeah, no problem.
Okay.
Start.
Lastly,
Yeah, start where you were there. Okay.
so I'll go back to the group of 1 to 5 years of age.
Yeah.
So they present with febrile UTIs. You want to examine, take a history, send off your urine, check their blood pressure, their GFR, and their renal function, and treat with IV antibiotics. The imaging would be an ultrasound to look for features of hydronephrosis or any structural abnormalities. I don't know why. Okay, there we go. You want to grade your reflux by performing a VCOG. So your low grades, grades 1 to 3, these are the asymptomatic group. If they present, you want to wait and watch and follow up these patients even annually. But those with high grade reflux, more than 4, you would want to follow them up every 6 months and consider giving them continuous antibiotic prophylaxis. Lastly, if the grades are more than 4 to 5 and present with a breakthrough, the indications that I've described, a breakthrough febrile UTI, you would kind of consider surgery in this group. And then once again, if they present with multiple UTIs, consider again secondary causes of reflux, and therefore urodynamic studies come into play. And thank you, and these are my references.
Okay, Neha.
Yes.
Thank you very much. That was quite an elaborate talk on a very complex subject, and you had collected a lot of information, and you tried to compress it in the 30 minutes which were allocated to you. So now I will actually formally welcome Professor John Lazarus, who is a professor of urology and head of division of urology at University of Cape Town and Groote Hospital and Red Cross Hospital as well. And he is the in-charge pediatric urologist at Red Cross Children's Hospital in Cape Town. And Professor John has a strong personal and professional connection to East London. He has also worked in our department for a short while, many years ago, and he has always been guiding us and helping us with complicated cases, which we have been sending to him over these years. So, John, I formally welcome you and request you to give your expert comments about the topic, in addition to your comments on presentation. But I think your valuable thoughts about this this complex topic of UTI and VUR.
Professor Chitnis, thank you very much for that very generous introduction. It's a very strong team you've got there, my goodness. And congratulations to Dr. Gautam for a very good overview, very sound, solid, and well put together. I can make a few comments, but I'm sure there might be some questions from some of the other colleagues who have some questions for Dr. Gautam.
Yes, please. Please.
I'm sure Dr. Majola's got something to ask. I see him there on the list.
Yes, he is there. We have decided that you will go first for the comments. Then Professor Colin Lazarus will go after you, and then Dr. Majola.
Okay. No, good. I think that firstly to say that it is a topic that has evolved quite dramatically over the years is vesiculoenteric reflux. And many of the things that one presents now are slightly outdated, and some of the things that one thought were cutting edge very soon have become outdated. And I always tell my colleagues it's a bit like prostate cancer, and maybe that doesn't mean too much to pediatric surgeons, but prostate cancer has got a bit of a bad rap because urologists have been very good at diagnosing it, and we have, as a result, overtreated prostate cancer. And my conclusion of much of the reading to do with primary vesiculoenteric reflux is that it's a condition that we have tended to overdiagnose and tended to overtreat. And I don't want to sound nihilistic about it, that we shouldn't be doing that, but I think that many of the stats that we took from the earlier studies, the famous pediatric urologist from Great Ormond Street is Philip Ransley, and he's kind of the father of reflux research. And he was able to show that reflux on its own in the pig kidney was of little consequence, but reflux plus infection resulted in chronic pyelonephritis, hypertension, and renal failure. And that panicked us as doctors. We thought, my goodness, this is awful. 1 or 2 bouts of infection, you're going to end up in renal failure. And another famous pediatric surgeon from England called Patrick Malone from Southampton, he had the Malone continence enema. He was able to show that the number of patients in a million children who actually end up in renal failure, and I haven't got the exact number to hand, but it's actually a tiny number. And it tells us the story that perhaps only a small number of patients are really going to suffer terrible consequences from their reflux. Added to that is a lot of medical uncertainty. We don't know if that original work from Philip Ransley is correct, because it's been shown, for example, that there are children in utero who already have scars from reflux. So it's not only reflux plus infection, but reflux per se, through a water hammer effect, may in fact cause trouble with the kidneys. And so there's a lot of basic science. What you said, Dr. Gautam, the first is that collecting urine is not quite as easy as you suggested. Getting the child to go and give a midstream urine, that's fine for an adult. But obviously, most of these children presenting are toddlers. And they are going to need to have a bag put on rather than being asked to give a midstream urine. So we like a bag. It's a very simple thing. And if it's positive, however, we would probably want to go on to do a suprapubic aspirate or an in-out catheter to get a specimen. So you speak to the pediatricians, that's probably what they would do under these circumstances. Because the bag may be contaminated. So you do want to go and get a clean specimen. So Melinda, I hope this is all making sense. I'm happy to continue talking, but also I don't want to dominate too much.
I think, John, you have given an excellent insight or introductory remark. So maybe we will have it as an interactive session. This is the first time we have invited somebody from outside our department to give expert comments. So we are also in a learning phase. So I think let me invite Professor Colin Lazarus to give his thoughts, and then we will go to Dr. Majola, and then we can come back to you, if that's okay.
Thank you, Milind, and thank you, Neha. My contribution is going to be very brief at this point, firstly, because I missed a lot of the talk through my own incapacity with the Zoom mechanism on a new computer, for which I apologize. And I missed a fair amount of the talk. Secondly, because I have a little corner of reflux that I'd like to discuss, but I'd prefer to do that towards the end of the meeting in relation to an interesting patient. So if I may, I would give the floor or the Zoom or whatever we do give to Dr. Majola at this moment.
Yes.
Go ahead and Kululeko. Thank you.
Okay, thank you, Colin. Okay, Dr. Majola, please. Dr. Majola has actually guided Dr. Gautam to prepare the presentation, and he's our de facto pediatric urologist in East London. So please, Dr. Majola, give your comments and views.
Good afternoon, everyone. Thanks, Neha, for the talk, which we had a bit of a struggle to try and get it to fit to the 25 minutes. The only things that I would like to just sort of correct in her talk. So with DMSA and a MEG3 scan, the mechanism or how the scans are done is also quite different. The DSMA is more of a static scan. So that will only give you the uptake, the concentration, and the excretion. So you only basically look at renal scarring and the differential within both the kidneys. The MAC3 scan as well is a scan for the kidneys as well to distinguish the uptake and the excretion, but it also tells you about any obstructions within the system, so from the pelvis to the ureters and into the bladder. But it's not a scan to distinguish if there's reflux or not. That is just an afterthought or an after effect where, because it's a dynamic scan, you can actually see when the child is starting to pass urine if there's anything that's coming out, because the scan is a dynamic scan, but it's never used just to see reflux. Then the other thing there that I would just like you to go through, just explain the mechanism of how renal scarring occurs in these kids who present with UTI. So it's just basically the pathophysiology. I might have missed it, or maybe just didn't go through it as we had spoken about during the week.
Okay. So it usually starts from lower down. So from your ureters, it extends to your bladder and then to your kidneys. So every time you develop a febrile UTI, you can develop sort of pyelonephritis, then scarring, and then hypertension.
Okay, so basically so with that, the renal scarring itself, as Prof said, there's two mechanisms. It can what we call a water shot mechanism, so the amount of reflux that goes up to the kidneys can destroy the cortex of the kidney. But in itself, if there's a febrile UTI, the only time that you get scarring or damage to the kidneys if you have a pyelonephritis. So if you just have a UTI and you are feverish, it doesn't mean that you're gonna get renal scarring. You have to have a confirmed pyelonephritis or infection within the kidney to give you those the scarring. Yeah, and then just on the minimal invasive techniques, as much as it's a new concept and also people are moving towards the performing certain procedures minimally invasive. It's a big learning curve, and also only high volume centers will be able to or who are skilled in laparoscopy to undergo these procedures, because you need a lot of numbers to be able for a person to get sort of good comparable quality between an open and a laparoscopic surgery. Yeah, I think that's my comments for now.
Okay, thank you, Kululeko, for, shall we say, your introductory comments. John, I would like to ask you a couple of questions, probably will be of use to each one of us. As everything in medicine, around 80s, 90s, it was hard hit. You see a cancer and you give the maximum treatment. You see reflux and you give maximum treatment. Now, the pendulum then later on slowly shifted to doing minimum. Has the pendulum come to the center? Do you think, are we doing the optimum thing or the right thing for the patients who need that particular treatment for reflux?
Well, that's an excellent question, and perhaps I can come on to it. I just wanted to really highlight three things, and I think what the question really relates to the third thing. The first question about reflux is, how do you investigate a UTI? The second thing would be related to how you interpret the literature, which I think is what you're talking about.
Yes.
So let's start with that first thing. Who and how are you going to investigate someone who's had a UTI? And perhaps I can share what we do in Cape Town. This is from the famous, I don't know if people can see that, the famous Red Cross Red Book. And you will be aware that there is this debate between the top down or the bottom up. And in days gone by, we were in favor. I hope you can see that, Milind.
Yes, yes, we can see. Yes.
Bottom down, the bottom up was better, the approach, which involved an MCUG.
Yes.
Now, an MCUG is an invasive thing. You speak to radiologists, they don't like doing it. It's a bit traumatic. And certainly in older girls, it is certainly overly invasive investigation. And the pickup rate in a child who's had a UTI is pretty poor. So it's an investigation that has its place, but we don't do it as a routine. We prefer the top-down approach, and we rely very heavily on our pediatric radiologists because they're such superb ultrasonographers, and they can pick up most problems very accurately nowadays with ultrasound. Of course, ultrasound is a poor modality to look for reflux because only the very severe grades are going to be dilating reflux that you pick up on an ultrasound. But you know, if you've had a UTI and you've got a normal ultrasound and you've settled and you've got undilated upper tracts, I don't think there's any reason to go on to do MAG3 or to do an MCUG. And I think the literature would support that. However, if you've had a second UTI or an atypical UTI, then you would probably go on to do the top-down approach, which would, in our hands, be a MAG3, looking for scars. And the debate is whether you do that early or late. We tend to do it late. And in older children, we will add on an indirect MAG3 to that. So we rely very heavily on nuclear medicine to investigate these children. So this is quite an important thing because you're going to be sitting in the clinic and you're going to be faced with a child with a UTI and you're going to wonder what you should do. And I think this slide is very helpful to know what to do. Taking one step back, if I may, for a moment, Milind,
Yes.
I think the key is for people sitting in the clinic is to have a classification for reflux. This is so crucial to understand the difference between primary reflux, which Dr. Gautam beautifully explained with the tunnel, et cetera, versus secondary reflux, which is reflux where the problem is usually the bladder, either neuropathic or following posterior urethral valves. And understanding that difference is key. And I don't believe we see too many cases of primary reflux in South Africa because of the ethnicity issue related to it being a familial thing, and it isn't as common as it is described in the books for the Northern Hemisphere. So you want to be very sure that you've got this case to be a primary psychiatric reflux. Dr. Gautam very well emphasized the importance of excluding bladder bowel dysfunction, because if you've got dysfunctional voiding, you're also going to be having a degree of secondary reflux, in which case managing the reflux isn't the key. Managing the dysfunctional voiding is the key with timed voiding, urotherapy, etc. Probably more important than whatever's happening at the VUJ. So, Milind, I think for the juniors, that's key to understand how important the history in the examination is to exclude causes of secondary reflux and to have this kind of schema in your mind when you think of investigating that. If there are no other questions or comments, we could perhaps come on to your question about where the pendulum is at the moment.
Now, I think that you emphasized it very well, John, and you clarified to us and basically to the juniors which patients they need to be worried about. And just to add on to your comment, Dr. Colin Lazarus has always been teaching and telling us that our patients don't read Western books. So I'm very glad that you clarified that our patients do not have same incidence of reflux, because we used to always wonder, are we not missing patients with reflux? Are our GPs and pediatricians not aware enough to diagnose them? But you have partly answered that question for me. So I think at this stage, I will ask Dr. Gautam if she has any specific questions for Professor John Lazarus or Professor Colin Lazarus, because she hasn't had chance to take their advice. Neha?
I just want to ask, in that flow diagram, what's an indirect nuclear medicine scan? What does that mean?
So you get the benefit of a cystogram, plus you get the benefit of a nuclear medicine study. The nuclear medicine is MAG3, which is almost as good as DMSA because it's able to show you scarring, and you're able to get differential function and see that one kidney is affected by scars and has reduced function. Once that part of the scan is finished and all the radionuclei has moved into the bladder, out of the kidneys into the bladder, you get the child to pass urine under the gamma camera, just like a cystogram, and you're able then to determine whether there's reflux or not. So it isn't invasive in the sense of requiring catheterization, and I think that's its benefit in older children.
Okay, thank you.
It sounded like Colin had a case, and I'm sure that's an excellent platform for us to continue the discussion.
Yes, I will invite him in a second, but John, just isn't it the principle mainly as minimal invasion during investigation as necessary, and endoscopic treatment or surgery only when necessary? Isn't that the concept and the principle now? With avoidance of radiation mainly for VCUG, which has big amount of radiation.
Yeah, sorry, I got confused there, Melinda. You're talking about treatment or investigation? Certainly investigation, we want to use the ALARA principle to avoid
I think, yeah, let's focus on investigation, just to emphasize to the juniors that avoid radiation as far as possible, and do VCUG in exceptional circumstances. Is that the correct teaching and the message?
Look, I wouldn't want to be too dogmatic on that. It's certainly true that a cystogram is far more radiation than a nuclear medicine study.
Yes.
But having said that, it's also about what access you have to facilities. If you don't have a very good nuclear medicine department, I should not be telling you not to be doing MCUGs, because they're excellent studies. They give you good information.
Okay. Okay. You know, we are lucky to have facilities of nuclear medicine, but certainly our radiologists or radiology doctors and ultrasonographers are not as experienced as you people have the advantage of. At this stage, I will call back Professor Colin Lazarus to share his case and give his advice and insight. Please, Colin.
So thank you, Milind. My case is from the other end of the spectrum. And so this is a 13-year-old twin girl, a 13-month-old twin girl. She's thriving. She was born a lot smaller than her sibling, and they are both doing well, although she's not quite caught up weight-wise with the sibling. Now, at the age of 3 months, she was admitted to the hospital with a febrile illness. And amongst the things, UTI was considered, but not confirmed. The urine such was examined, did not confirm the urinary tract infection, but in the process, she also had an abdominal ultrasound done, and surprisingly showed only a single left kidney. She was then investigated further at about the age of 6 months. And those investigations included an MCUG. And that surprisingly showed grade 5 reflux through the dilated ureter into that single left kidney. Now, she had a MAG3 study done, which showed a dilated but not obstructed left kidney. But they wondered on the MAG3 whether there was a cortical defect at the upper pole of the kidney. So one doesn't see that very clearly on a MAG3. as far as I'm aware. So subsequently, a few months after that, she in fact had a DMSA scan, because one was concerned if that cortical defect was real, then the one remaining kidney had already been damaged. The DMSA showed possibly a tiny cortical defect. So she went home. She has been at home the last 6 months. She's not had a urinary tract infection. She is well and growing, and she's not been on antibiotics. She's now 13 months old. So in summary, she is healthy. She may or may not have had a urinary tract infection at an early age, but she has a single left kidney through with reflux at a grade 5 level up to that kidney. So what would be the principles of management? That's my question. Thank you.
Thank you, Colin. I think Neha, you are best equipped to answer that question right now. You have done the reading.
So, Prof, so just to summarize, so she has high-grade reflux. She has one kidney, and we're not sure if she has renal scarring. So I would like to follow up. Maybe I would follow up in the next 6 months. I would perform another renal ultrasound. And what I would like to look for in the renal ultrasound is, again, the growth of the kidney, the cortomedullary, the cortical thickness, the AP diameter. And if that looks relatively normal, I will still wait and watch. If she does develop features suggestive of hydronephrosis, the next investigation I would do is, I'm more familiar with a MAC3 scan, and I would like to see what's her split function. Is there any obstruction? Is there any, is there uptake and excretion? Is that good in that kidney? If there's nothing found on that investigation, I would still follow up regularly with another renal ultrasound. That would be my plan. So I would not intervene yet. I would rather watch and wait and do my investigations, non-invasive investigations.
Okay, just one correction, Neha. You can't say split function because she has got solitary kidney. Colin, you can just, I don't know what, whether you got the answer you expected or you would like to tell us. Hello, Colin. Colin. I don't know whether Professor Colin Lazarus is still connected or is having internet connectivity problems. Maybe because we are struggling to get him in. John, can you give your input on Colin's question, basically for Neha and for us? Sorry, 1 second, John. I'm just unmuting you. Yeah, sorry. Yeah, I've
Yes.
unmuted you now. Yeah.
Yeah. Perhaps I can take a little bit of a long view of the case before giving what I would say we would need to consider as a plan. You know, the first thing from the junior's point of view is when you hear that the child's been told that they have a single kidney, you can't accept the ultrasound as giving the definitive answer there. And a MAG3 or DMSA scan would be important because you would suspect that many of these kids are going to have a pelvic kidney. So that was done, and an ectopic kidney was excluded in this case. The second thing that Colin hasn't mentioned is the bladder. In other words, we've got to be 100% clear in our minds that this is a case of primary reflux. And the reason why that's so important is because I personally have very been close to doing a colon reimplant, thinking this is a case of primary reflux, and I hadn't quite focused on the posterior urethra, and it was in fact a boy, and there was a subtle feature of a posterior urethral valve, and that needed to be ablated before one contemplated anything fancy with the ureters. So be very clear in your mind that you're dealing with primary reflux and that there's not a secondary neuropathic or copum related problem. The second thing that I think is quite important to do in this sort of case is to get a baseline GFR. Creatinine may be helpful if it's just a single kidney, because I think you are wanting to find evidence of this kidney being in further trouble, which would push you towards doing something surgically. So a baseline GFR would be important. And I must say, although we've spoken against continuous antibiotic prophylaxis, I think a case like this of high-grade reflux, single kidney, I think you could make a reasonable case to the parents to offer them antibiotic prophylaxis. Because your argument would be that one further episode of urinary tract infection can potentially cause further scarring, and you'd really want to avoid that at all costs in this vulnerable kidney. The last thing I think is worth discussing is an understanding of the natural history of reflux, and if this is primary reflux, by about 2 years of age, you'd expect that the reflux should have resolved. So the natural history of primary reflux is to resolve, and it usually takes about 2 years. So that is also something you need to factor in to your decision-making about what you're going to do with this reflux. I don't know if Colin's there, and it's a pity he hasn't got some pictures to show us, because that would certainly mind about what to do. So I've spoken a lot of generalities, but perhaps other people have got comments about what they think should be done.
No, I think I'll invite Dr. Majola in a second, but I'm so glad that repeatedly you are emphasizing to all of us to rule out secondary causes of reflux, even in a girl. I think that is very important message for us to remember before we plan a fancy operation of reimplantation or try and do an endoscopic procedure. So that is a very important message which we need to take home. Kululeko, please make comment about Dr. Colin Lazarus' case.
Thanks. I was also just going to say I would aim more towards a more conservative management in the case of this patient, with regular follow-ups, making sure that there's no other anatomical abnormalities, making sure that the kidney is functioning well, so that if you see there's any sort of problems earlier on, then you can intervene early. So instead of, I'll say our normal in inverted commas follow-up of 6 months or so, I would do it more regularly, maybe on a 3-monthly basis, and definitely make sure that the child doesn't develop any urinary infections and also febrile UTI. So always check the urine as well to make sure that it is sterile as well when they do come in. But my question, just as a diversion to Prof. Lazarus to join, if in this case, because we've Prof. Colin has mentioned that there is some form of something that they see on the upper pole, which they're not sure if it's scarring or not a scar, would you then intervene early as to maybe endoscopic procedure or do a reimplantation just to try and protect the kidney? Let's say it is a scar that they've seen already in the upper pole.
Yeah, Dr. Majola, that's a very good question, and I think you're hinting that this child deserves intervention. I wonder if I can ask Dr. Gautam to pull up her slide from the Swedish reflux study, because I think that is quite helpful in this setting to know what to do.
Neha?
The point that I'm trying to make is that...
Can you share your screen again and put that Swedish study slide, please?
I'll do that shortly. Okay.
So that's very helpful. I think the point that I want to emphasize with this study is that these were children who had more high grades of reflux, if I'm not mistaken. They weren't
Yes.
just ones and twos. And that bar chart shows very nicely the outcomes of those children who were randomized to surveillance, prophylaxis, or a anti-reflux procedure using deflux, a sting procedure. And what I take from this slide, and I'm just trying to see what the bar is there. I presume it's, can you tell us what the y-axis is there, Dr. Gautam?
I think that was percentage of febrile UTI versus the three groups: prophylaxis, endoscopic, and surveillance.
Yes.
Yeah.
Yeah. So look, I think we're offering Colin's child surveillance at the moment, and you can see there's a pretty good chance of another UTI.
UTI.
So that perhaps isn't so appropriate. So your choice then comes between giving prophylaxis and doing something endoscopically. And I would want to argue that doing something endoscopically is a good option. No parent likes giving their child a daily dose of antibiotic. And there are some concerns about long-term antibiotics in the pediatric age group that you could look up. Endoscopic anti-reflux sting is a very simple, straightforward, uncomplicated day case with very little sequelae in terms of complications. And you can see from the Swedish reflux study that it basically solved the problem. And so I'm very much in favor of telling community urologists to consider offering this for children who warrant it. Can't make the decision about who needs it, but certainly in terms of management, I think it's not a bad option for people who are not that familiar with doing cone reimplants every single day, or laparoscopic leash gregoire for that matter. And I would, the question that obviously comes back in Colin's case is, well, is it going to work in a child who's already got a grade 5 reflux? And there's some reasonable good evidence out there from a guy called Andy Kirsch from Atlanta in the United States. And he makes the point that although you may not cure a grade 5 reflux with a sting procedure, or in his case, he talks about the HIT procedure, which you can look up is slightly different. He says, although you may not cure the grade 5 reflux, you certainly reduce the grading. So it goes to a grade 1 or 2 after being a grade 5, and it can be repeated as sting. Although certainly after the second sting, I think it's advocated that you don't do anything more after that. So I think that would be my answer in general terms to this child who is at risk with a single kidney, who has very significant dilating reflux, presumably, and who has had a possible UTI. I would be inclined to treat. If the parents are against, I would still encourage them to take continuous antibiotic prophylaxis. I think medically, legally, you would be backed up by the RIVUR trial if the child were to run into mischief later on. So that's a long-winded answer. I'm sorry, Professor Chitnis, but maybe we can discussion. Other people might have different opinions.
No. I think it's a convoluted topic. So I think your answer is according to the topic. So it's not a straightforward road in a Karoo, but this is almost like Chapman's Peak Drive. Unfortunately, we lost Professor Colin Lazarus, but I see he's back. So Colin, unfortunately, we lost you for a while, but would you please give sort of your guidance to Neha about what is your approach to your patient and what is your basis for your approach, please?
Yeah, thank you, Milind. Yes, I did not lose you, but I was lost from you.
Yes.
So here we are. So I want to thank John very much for his comments. The need to assess the GFR and I think that is valid. and to remember that there may be, even in this girl, something wrong with the bladder is also, I think, very important that we be sure of that. So it happens, I saw this girl today for the first time in 6 months. And I've not had an opportunity really to spend time thinking about the management. But I know she's been free of urinary tract infections for those 6 months. And I wonder, even if she'd been on prophylaxis, whether she would have, in fact, been free of infections. I think we have to be very careful before we assume that urinary prophylaxis does, of necessity, make a difference. So I will be seeing and talking to the family in the near future. Yes, we do need a new ultrasound, and that's easy to do with regard to seeing that there's no further dilatation of the hydronephrosis in that kidney. I probably would want in the next few months to repeat the nuclear medicine study. But I'm not sure about the intervention and whether I would be justified in saying, why don't we wait for at least one further urinary tract, at least one confirmed urinary tract infection before we do anything further, if we don't see any other deterioration. It's just making a case. No doubt we'll talk about this a little more. Thank you.
Thank you, Colin. I will invite John to just make a brief comment on that. But I don't think there is absolute right or absolute wrong, if I understand it correctly. I think there can be support for each argument, as long as it is carefully considered. And as John said, we have scientific basis for it, and we consult and discuss with the parents. So John, you can give your opinion on that. And we have 2 questions also. So I think before we close, I would like to ask those questions to you. So maybe first your comment on Colin's plan, if you may.
Yeah, I think it's a balance of probabilities and risks. Undoubtedly, this child would have some features that would prompt one to do something. But having said that, the child has a undilated system, if I understand Colin correctly. There'd be no further UTIs. The story of the initial UTI and the scarring is in question. And he's got the natural history on his side. The child's made the first year. He only has to hopefully get to the second year, and things may well settle down. So I think a Eurovigilance would be very helpful here, to have educated parents who have dipsticks at home with some urine bags, who can be quite active to monitor for urinary tract infections and get it treated early before it becomes a nasty pyelonephritis.
Okay, John, thank you. There are 2 questions. So one question is from our medical officer, Dr. Pedersen. It's in the chat group. I'll just read it. In primary vesiculotic reflux, is there a period where it will worsen first before starting to resolve? Or is any sign of worsening disease an indication to intervene? John, if you can answer that, please.
Yes, I don't know that we regard it as something that worsens. I think it's it's coming back to Dr. Gautam's reasons to intervene. And many of those reasons that have traditionally been mentioned have in fact been questioned in terms of their validity. For example, children who are approaching adulthood, who may become pregnant, girls, we wanted to intervene even if their reflux hadn't resolved, and that hard and fast indication has been called into question. So each of those things that you mentioned, Dr. Gautam, there's a fair bit of body of literature on all of them. But in general terms, higher grades of reflux, children who are not prepared to be compliant, children who've got some VUJ anomaly that might not going to resolve, and those with evidence of scarring and kidneys that are not growing would certainly be at much higher risk and push you towards intervening in primary reflux. Thanks, Melinda. Any further questions?
Sorry, Colin. Sorry, John. There is a question about what is your opinion on HIT, hydrodistension implantation technique?
Yeah, so it was originally Prem Puri, the famous Dublin, and Barry O'Donnell, I think, who devised Teflon injection, and they called it the Sting, from subtrigonal injection, I think is what the acronym stands for. And the more modern version of that is something called the HIT, where you use the cystoscope's jet of water to open up the ureteric orifice, allowing the scope in many cases to get inside the ureter, and then to inject the bulking agent at 6 and 12 o'clock and hopefully coapt. I must say it's not always possible to do that, in which case a Sting is perfectly fine. I haven't read anything in the literature that said one is better than the other. I think it's just an evolution of the technique, and it's about in your hands what you can feel confidently that you're able to reproducibly get a coaptation of the ureter.
John, thank you very much. I think this was extremely useful, and this meeting just went in the way we wanted it to go, that we had half an hour of presentation, but almost another 45 minutes plus of advice, opinion from experts. And we really appreciate you spending your time and sharing your thoughts and expertise. And unfortunately, we haven't managed to get you physically to be with our team for so many years, even though we both of us have been planning about it. But with this pandemic, at least we can get you invited into the virtual Zoom meetings. So I really thank Dr. Gautam for her excellent presentation, Dr. Majola for advising her all the way through, and Professor Colin Lazarus and Professor John Lazarus for their insight and for their expert advice, and all the participants which come from as far as Gauteng, not only in the Eastern Cape. So thank you all and have a good evening. The meeting is being recorded, so I will put the link on the group, and anybody who wants to access it can then access it afterwards. Thank you, John. Thank you, everyone. We'll see you next time, John. Bye-bye.
Bye-bye.
Thanks, bye.
Bye.